Hello everyone, my name is Mehanna. I am the scientific editor for the IAPRD website, and today I have the pleasure of talking to Richelle Flanagan and Indira Subramanian regarding their recently published article, The Missing Piece of the Puzzle, the Key Role of the Dietitian in the Management of Parkinson's Disease. How does nutrition impact on the non-motor symptoms of Parkinson's disease?
If you think of the digestive system, from the mouth onwards, a big problem for people with Parkinson's is that they find it difficult. They lose their sense of smell, they lose their sense of taste, not eating food because it doesn't taste as nice, it doesn't smell as well, and that can lead to weight loss. Then 80% have dysphagia issues, swallow issues, and obviously that can have a big impact on nutritional intake as well. There can be problems with saliva, the stomach. We have issues in terms of gastroparesis, slow gastric emptying. So it's said that in some research that up to 100% of people with Parkinson's along the journey will have gastroparesis. Sort of the intestines, there's problems in terms of malabsorption, so things like vitamin B12 malabsorption. And then obviously a big thing is constipation. Up to 60-70% of people with Parkinson's suffer with constipation, and that has a big impact in terms of nutrition. The effectiveness of medication working, it impacts people's ability to eat. It causes bloating and all sorts of knock-on effects. The problem of weight loss. So malnutrition is a big problem in people with Parkinson's, and we know from the research about 24% can present with malnutrition, and up to 60% maybe are at risk of malnutrition. And on the flip side, you've also then people who gain a lot of weight, maybe post DBS, or taking, because the medications, they are overeating in terms of impulse control. We've got things like sarcopenia, which is, muscle wasting. And again, the research shows that maybe 24 to 67%, it's quite a wide range, can suffer from sarcopenia, which is a big risk in terms of falls. And obviously that's a big risk for people with Parkinson's who have a higher fracture risk. And then also in terms of osteoporosis, bone health, there's a big problem in terms of their fracture.
I'm a neurologist, just to put this in context, and Richelle is a dietitian and also a person living with Parkinson's disease based in Ireland. And so we ended up working on this paper together with another dietitian or two, really thinking about, sort of how we can, come together as a patient voice, a dietitian voice, and a neurologist voice. So I'm interested in wellness and the concept that, things that are lifestyle choices, exercise, sleep, mind-body practices, social connection, but nutrition is a big piece of this as well. And from, how can we impact constipation, which is a major issue that plagues many people with Parkinson's disease. So, for example, increasing fiber, increasing hydration. There are various types of nutritional aspects that I'm sure Richelle can comment on that can help constipation and sort of just the gut microbiome as well, which can actually impact a number of non-motor issues. From a mood standpoint, actually, there's many things that can impact mood from a nutrition standpoint as well. So there's a whole field of neuropsychiatry and the gut that is actually quite fascinating. And so, ways to sort of impact that can include more plant-based, less processed food, less sort of sugar-rich food, things that are going to be more fiber-laden, that are going to help sort of even out the ups and downs of sugar in the blood system and in the brain, can actually impact mood quite potently. Decreasing caffeine towards bedtime can impact sleep. So there are a number of ways that actually nutrition can directly impact non-motor issues from a wellness standpoint as well.
The next question, what is the role of the dietitian in the multidisciplinary team?
So what the dietitian does is personalize, nutritional therapy for that person in front of them. So we would look at their background in terms of, their culture. We'd look at their lifestyle in terms of, are they young onset? Are they working? Are they doing a lot of exercise? Are they more advanced stage? In terms of, do they have dysphagia problems? Do they have comorbidities? So we know that diabetes is a risk factor for Parkinson's. So what if a number of people with Parkinson's would have diabetes, or they might have underactive thyroid, or ulcerative colitis, inflammatory bowel disease. So we would have to look at the whole person in terms of tailoring their dietary needs to the person in front of us. And we take into account the symptoms that are happening, in terms of whether they're suffering from, for example, gastroparesis. As Indu has said there, generally speaking, we'd say in terms of constipation, to advise people to take more fiber. But in the case of, say, someone with gastroparesis, it's actually the worst thing we can do because of the slow gastric emptying, it makes it worse. So I suppose this is where it's about tailoring to the person in front of you, and working with the neurologist and the other health professionals. So we would, link in with the speech and language therapist and flag if someone is reporting problems around their swallowing. You'd refer back to the neurologist if there are issues around gastroparesis that needs maybe some further sort of medication intervention. We would, link in with the Parkinson's disease nurse with regard to, saying that they might need some laxative intervention. So we're kind of like a signposter, and we do a lot of education for clinicians as well about the importance of nutrition for people with Parkinson's. And, it's a big problem in terms of sort of lack of awareness of the dietary needs of people with Parkinson's. So that's something that really needs to change.
And as a neurologist, I think, we have less and less time to spend with our patients. We have increased complexity of patients, and we really are, struggling sometimes with 15 minutes every 6 months, sort of trying to do everything from medication reconciliation to counseling. I'm a big believer in writing papers with a number of voices and a lot of collaboration. So I think I am a cheerleader for my patients, but obviously we don't have the time to spend doing that continuously for those times that we can't see patients. And so I think using extenders of care, be it a physical therapist from an exercise perspective, and I really have enjoyed sort of collaborating with the dietitians to learn so much about what they can do. A referral to a dietitian can give a patient an extra set of eyes and sort of cheerleading for some of these lifestyle choices on a regular basis. They can really take that time to understand, perhaps even access issues. Does the patient have money to buy, food, and able to, execute the things that we're talking about in terms of, cultural sort of sensitive diet things. We can have cookie cutter choices and slides often that we talk around that are very much based around affluent Caucasian populations. But I think, taking that care and really providing it in a bespoke way for whoever may be in front of us. Women, for example, and their needs dietitian-wise, dietary-wise, are very different than men. Often they're more at risk for weight loss. They have different choices that may be available to them. Some women are interested in, perhaps intermittent fasting or keto or other things. And so we really have to understand sort of, what the patient, the person living with the disease has in their mind as to what may be nutritious for them and help advise them. So I've really enjoyed sort of taking the time to understand. I think often when we refer to dietitians, it's way too late in the game. Often when patients are already losing weight or needing to have their diet modified because of swallowing issues. And I've been excited to work to understand that, perhaps an earlier referral, even sometimes from perhaps diagnosis in some cases, may be actually beneficial to help sort of set the road to success.
Not many people with PD have access to dietitians. Why do you think so?
Well, we know in terms of the research to date that, up to 85 to 90% of people with Parkinson's don't have access to a dietitian, which is appalling. And I think, part of that problem is that multidisciplinary care for people with Parkinson's in worldwide, is not actually the norm, unlike how it happens in cancer or diabetes or heart disease. We are behind the curve. We're not as lucky, like in Ireland, we have the worst access to a neurologist in the whole of Europe. So trying to get a multidisciplinary team is difficult. So I think part of it is, awareness raising about sort of multidisciplinary teams in general worldwide. But in terms of diet, I think it's been lost. There's a lot of focus on the exercise and, for Parkinson's, but there actually is building research showing that diet could definitely helps to alleviate symptoms like exercise does, but also potentially slows progression. I think part of the problem is probably neurologists it's not just neurologists, other, consultants get like, I think, half an hour training in nutrition in their training. So it's not something that they're really aware of. And we did a focus group with people with Parkinson's in the UK and Ireland, and it was quite shocking how they said that basically the neurologists did not know anything about nutrition, were quite dismissive about it. But on the flip side as well, they were quite negative about the dietitians in terms of there was, different advice been given, and some of the dietitians weren't up to speed in terms of Parkinson's needs. And that partly is because there's no training specifically for dietitians in Parkinson's nutrition as well. So there's a number of things that are at play here. And also I think in terms of people with Parkinson's themselves don't think of asking for referrals. So I don't know if it's the same in the States, but if you don't ask, you don't get. So that is something as well as people, realizing that diet can actually make a big difference to their Parkinson's and how they feel.
We're really very reactive in treating Parkinson's. We wait for symptoms to occur and then we treat them with medications or surgeries. We haven't really had a sense of prevention, wellness, sort of proactive sorts of brain health approaches. And I think, my sense is that the time is changing. And so we have to think now about food as medicine, as is exercise as medicine, and really counsel about this proactively. And so if we can start to build guidelines, and we've talked about that, we sort of have a call to action in our paper with action items talking about educating every dietitian with some basic things about Parkinson's, making resources available throughout the world on basic recommendations for Parkinson's patients, and really including dietitians as part of the multidisciplinary team, as we might a physical therapist or a social worker or a psychologist. So I really think that, we've been able to partner and come up with a paper that has some very basic sort of call to action about how we should all be doing this more. And I think, perhaps one visit early on at diagnosis to help, sort of pave the way, as I mentioned, checking in with the dietitian along the way, being proactive and helping them to feel, also like they are a proactive member of the team. It really is unfortunate when, the only time we engage psychologists are when people have already, become psychotic, or, a dietitian is only engaged when somebody needs a G-tube. I mean, I think that's really, the cat is way out of the bag, and they have a lot to offer from an information and proactive resource and wellness standpoint, in my opinion.
When we think of neuro rehab, often we think of sort of the other therapies, physio, it's hands-on, speech and language, it's, neuro rehab of the swallow. OT, it's rehab of their function. And so often people don't think of nutrition as part of that rehab, but actually the nutrition is the foundation, because if you are malnourished and you are sarcopenic, no amount of exercise is going to work because you are so fragile, and frail. In fact, it might, be counterintuitive. If someone has a swallow issue and they're put on a dysphagic diet, like a soft diet, that is going to be nutritionally lower in nutrition density if a dietitian doesn't actually modify that diet to make sure that it's got enough calories and nutrients in it. And in terms of an OT, maybe helping in terms of cutlery or that, again, a dietitian needs to be part of that to see, well, what is the issues around when they can't get enough food into them because they have a tremor and they can't cut their food. Well, do they need other nutritional supplements to help balance that dietary deficit out? So it's a missing piece of the puzzle in that neuro-rehabilitative approach of the other therapists.
That's fascinating. You're pushing me to get convincing me, I should say, to get the dietitian very much on board for every single patient. That's great. So then if we were to give one core advice to improve the nutritional care of people with PD, what would that be?
I'd obviously say a referral to a dietitian because, and it's not about, and I will say it's not about jobs for dietitians. Like, I am a dietitian, I live with Parkinson's, and I do a callback service for the Parkinson Association in Ireland. And I have to say, I actually come off all shocked every time in terms of people that are left with swallow issues, choking issues, with constipation where they're having to manually evacuate their own bowel, with gastroparesis where they're losing such amount of weight because they're not getting access to a dietitian who can really help to help with some of what I call low-hanging fruit in terms of helping to improve a lot of those symptoms. It actually makes the neurologist's life easier, that you're not having people pinging into your clinic with things that really should be dealt with by a dietitian as part of the multidisciplinary team.
I think weight loss is a harbinger of bad things in our patients, and I think that we need to be tracking weight loss aggressively, and when there's sort of this point, and it happens earlier for certain cultures, Asian cultures, for example, and women, dyskinetic women, lean women, this is not a good thing. We need to be sort of, jumping on there, because sarcopenia, bone health, all of these things can be impacted and fall risk with bone fractures. So I think, weight is something that I never really realized is so key, that we need to be aggressive about. And I think a lot of what we do, again, is standardly around a Caucasian male sort of figure, that we may not need to worry about weight quite at the same point. But for some of our populations around the world, weight is very key. And just if I could put in one other point, in a disease where we rely on the gut to absorb drug, levodopa is so protein sensitive actually in many patients. And so we actually wrote a sister paper with the same team on protein and its effects on in Parkinson's patients. And so urge our readers out there to take a look at that paper as well. Again, patient voice with dietitians, but I learned a lot just to understand, how much protein can affect absorption and how we can sort of position protein in the day. And we put a number of tips on that paper.
Great. Well, thank you very much, both of you.
Promise.